So we're going to do a presentation on pressure sores. So pressure sores are an area of damaged skin or underlying tissue caused by direct pressure or by shearing forces. They also are known as decubitus ulcers, bed sores, bed ulcers, or as we're going to call them, pressure sores. Just important to note that leg ulcers are not the same thing. They are due to a vascular problem and are distinct from pressure sores. There's also something called moisture lesions. They can look very similar to pressure sores. You could also get a moisture lesion developing into a pressure sore, and in fact, any sort of wound could develop into a pressure sore. There's different categories, previously known as stages. You have category 0 or 1, which will look the same. They'll both appear to be red. The difference is that if you touch the redness, then if it's category 0, it will momentarily blanch, or where it goes like a lighter color, a white color when you press on the redness. Now, if it's category 1, it will stay red when you press it, so it'll be non-blanching. I believe also category 0 could be referred as marking by some people. So the actual pressure. So what's happening is if someone lies or sits on a part of their body that is that we'd refer to as the pressure areas are more susceptible, where they have a more bony prominence. And less subcutaneous fat that's cushioning that area of the body. So like the hips, the sacrum, the heels, the elbows, anywhere where there's bone that's more prominent. So what happens is they lie or they sit on this area, and that pressure reduces the blood supply to that area of the skin, and it can obviously if it's not getting the nutrition, the oxygen, then you're going to get some death of the tissue there. So that's how the actual damage is caused. And then when you're seeing like the grade 0 or the grade 1 pressure sore, you see that redness. That's the body's like diverting blood into the area to try and repair it. Category 2, that is where the skin is now broken down, so it could be completely gone or it could be diffusely gone, as in the picture. Just to note, you don't necessarily have to start grade so category 0 and move to 1, 2, etc. The development could jump up. If you did get a grade or category 0 and you turn a person off that area, it should heal. The damage is not permanent like a category 1, so turning is the most important intervention. Category 3, previously known as stage 3, that's where it's gone deeper down. So you've got two pictures here. You're starting to get a cavity forming in this image. This is going down into the muscle. This is getting quite serious now. It's going to hurt. It could get infected. If it carries on, the damage carries on, you're going to get a category 4, where you might even be able to see the bone below, for example. Both these images are category 4 sores. Very difficult to heal. Take a long time for them to heal. They're going to cause a lot of pain for the individual, and there's a big risk of infection. And then you've also got unstageable, where the depth is unknown. So this like schematic diagram is showing you how the tissue is going to be damaged. and this is an image of an unstageable in real life. So this black tissue here, this is dead gangrenous necrosis. So it's completely dead, and it would have to eventually come off the wound, because it's just not gonna heal. But we don't know how deep the damage is from this just looking at it. You also get suspected deep tissue injury, also depth unknown. So this is how it may appear on the heels. So what causes them? So we talked about the pressure. I described that as I was going through the categories. You can also get something called shearing. For example, if you sit someone up in the nursing bed, you can get like gravity will bring tissue downwards, and that can occlude the blood vessels. So you're getting a tissue malnutrition from those deep blood vessels from supplying the tissue. So that would be the shearing damage. And then, so those are the two ways it actually happens, is the pressure and the shearing. And then the others will contribute to that area of the skin being susceptible to the shearing and pressure damage. So friction. So for example, if you keep pulling the sheet to move someone in the bed rather than using a slide sheet, you're going to get friction on their body, which will weaken their skin, and you could get then pressure or shearing damage. Uric acid, which you're going to find in the urine, if that gets on the skin, it's going to weaken it. The feces or the stool, if that gets on the skin, it's going to damage it. You might have heard people referring to fecal burns. So obviously any damaged skin can go on to develop into a pressure sore. Any moisture, so the skin, if it's too moist or too dry, it's going to be weak. So if they've got like a fever and they're constantly like sweating, their skin's going to be moist. It's more susceptible to pressure damage. But also if you've washed them and you haven't dried them properly, that's also going to damage the skin. But all of them can contribute, but pressure is the most important, and it's the way the damage actually occurs. Why are they so serious? Because they can be extremely painful. It may be the reason why someone has to have like morphine sulfate tablets or Oromorph or a Butrans patch for the pain relief, because they're a pressure sore. They can lead to infection in the bone, which is called osteomyelitis. You can get infections, and if that infection becomes very serious, it can lead to death by sepsis, or morbidity due to sepsis. This may be sound unbelievable, but on average, pressure sores cost about £60,000 to the economy to manage. So just like a category 1 redness, it's going to take minimal intervention. But if you get a category 3, 4, it's going to be costing a lot more money due to the infections. It might lead to intensive care admission. It could be the reason someone has to come to a nursing home. Some of the dressings that may be used are very expensive. You're changing them quite regularly. You get the specialist tissue viability nurses need to see that person, etc., etc. So the money could be even more than 60,000, but on average it costs £60,000 per pressure sore. They're very difficult to treat, and they increase the workload of staff, because you might have to keep people turned so the nurse can do dressings, etc. And a key point is 95% of pressure sores are preventable. There's going to be some pressure sores that whatever we do, they're still going to develop, but most are preventable. As they're so preventable, they're a sign of poor care. A lot goes into preventing pressure sores, so they are an indicator of overall poor care in a nursing or residential home. As such, the Care Quality Commission will want us to inform them of the numbers and incidents of pressure sores in the home, as it's a marker of the care in the home. We could get poor reputation, so we won't get admissions. So they're very serious. So we need to try and prevent them. So how do we prevent them? Because it's all about prevention with pressure sores. So any problem in nursing, we look to the nursing cycle. So we assess, and then based on that assessment, we produce a plan, we implement that plan, and then we review and go round as appropriate. So if we apply that to pressure sores, we will assess all residents on admission for the risk of developing a pressure sore, and we will use this official risk assessment called the Waterlow score. And that should ideally happen within 2 hours, as a pressure sore can develop within 2 hours, but it should be less than 8 hours. It's subjective. If one nurse does it, they might get a higher score than another nurse. But also we need to apply clinical judgment when you're carrying out this risk assessment, and it's just an indication. You can't put all decisions based on the risk assessment, so you need to use your clinical judgment experience as well. Once we know the general risk that a resident has, we will then produce the care plan, so the pressure sore prevention care plan, and that should be based on their individual circumstances. It should be person-centered, evidence-based, and it should be based on that risk assessment and what the particular risks are. So we should be able to read the care plan, and it should tell us everything we need to do to prevent a pressure sore developing in that individual. And then the nurses and the care assistants need to implement what's in that care plan. And then we need to review the care plan and the Waterlow score risk assessment monthly, and when there's a change in the resident's condition. So if someone's been admitted to hospital and they've been there for a few weeks and then they get readmitted, we need to reassess their risk of pressure sore development. If someone's mobility changes, it's the same. If someone has an acute illness or a respiratory infection, they need to be reassessed. So this was the old like Standex Waterlow score we used before. Now it's all digital on the Nourish system, but it is the same. So the first thing we look at is their body mass index, so their height and weight ratio. If it's normal, they don't get a score. If it's above average, then they get a score of 1. If they're obese, they get a score of 2. Now that is due to immobility and due to loss of sensation in parts of their skin due to the increase in weight. But the bigger risk is if they've got a body mass index below average, because they have less subcutaneous fat to cushion their bony prominences. So they're a lot higher risk if they've got a lower BMI. We also look at the skin. So if they have something called like tissue paper type skin, they get a score. If it's dry, if they have edema, which is swelling, they get a score. If they've got clammy skin due to let's say they have a fever, then they get a score. Any current discoloration, any like category 0 sores, for example, or any existing like grade 2-3 sores with broken skin, then they'll get a score for that, a higher score. Because if you have a pressure sore, you're very likely to get another pressure sore. Continence. So continence is the ability to control when you pass stool or urine. So if you're incontinent of urine, that's a risk, because the urine will have uric acid in it, which will weaken the skin, and also it will make the skin moist, which will make it weaker. So that's a risk. The feces or the stool as well, if that gets on the skin, that's gonna damage it, weaken it. so that'll provide a score as well. Mobility, so that the risk goes up a lot with immobility. So if someone's bedbound, that's the highest risk, and if someone's mobile, completely mobile, then that's the lower risk. Males, they don't get a score, but females do. Not 100% sure on the reason. And then the risk goes up with age significantly as well. There's special risk factors such as smoking, diabetes, stroke, if someone has anemia, if they have paraplegia, if they've had orthopedic surgery, if they're on certain medications like high dose steroids or other cytotoxic medications, then that would be a risk. And lastly, there's the malnutrition. So if they're not eating and drinking well, then the skin is going to be weaker. So they'll get a score if they've been losing weight and not eating and drinking very well. Now we add up the score, and at the end you'll get a number. So if it's 10 and above, they're at risk of getting a pressure sore. 15 and above means they're at high risk of getting a pressure sore. 20 and above, they're very high risk of getting a pressure sore. So that's the Waterlow score, and that's how we'd calculate it. Prevention. So once we've done the Waterlow score, we would then write the care plan based on that score, based on our clinical judgment. We would try and work with the service user as well, any relevant others to produce that care plan. Some of the things, it should be individualized, but some of the things that we could put in there and what we'd have to implement would be as follows. So when they're at risk, so from 10, a Waterlow score of 10, we'd say we'd at least have a foam mattress. And then we would say that this is our own sort of like experience. We'd say if their Waterlow score of 15 and above, alternating air mattress should be in place, and that should be set to their weight. You should check that it's working every time you care for them. Report any faults to the maintenance staff, or try and fix them yourself if you're competent. Ensure it's not set on static, only for the moving and handling intervention, and then put it back to alternating. And then we may need to do things such as floating the heels. Even if they're on alternating air mattress, we may need to float their heels using the foam cushion that they may sit on in the bed. We could use what we'd call prophylactic dressings, and I believe a hydrocolloid would be the best for that. But just be aware, if you put a dressing on, you can't see what's going on underneath that dressing. So you need to consider if it's going to be a benefit or a hindrance. When they're sitting down in a chair, they should have a foam cushion, but more importantly, the chair should be an appropriate height for them. It should have adjustable legs, because that's actually more important to evenly spread the pressure when they're sitting down over just a foam cushion. Turning and repositioning. So this is the most important thing to stop someone who's bedbound from developing a pressure sore. So you want to be doing a 30-degree tilt. You don't want to be going like, let's say, 90 degrees, because you then turn them onto a bony prominence on their shoulder. So it should be a 30-degree tilt. And there's no evidence base to suggest how often to turn them. Just based on my own experience, I'd say Waterlow score of 20, we'd turn them 4 hourly. Waterlow score of 25, we say 2 hourly, or maybe we may even go up to like hourly. But there is no evidence base to suggest how often repositioning should take place. Obviously, if they have got a sore, let's say on their sacrum, then you'd ensure they only turn on their left and right. Make sure there's no crinkles or in the sheets or the clothing, because that will dig in, and that could start a pressure sore developing. We always promote continence, so if someone asks for the toilet, that's a priority. The incontinence products, the diapers, etc., they are just for safety. Always offer the bedpan or the commode or the toilet. If there is someone who just severe dementia, they can't communicate with us, and we have to rely on the incontinence product, then we need to check it regularly. We need to make sure that their skin's cleansed appropriately with the appropriate product, skin cleansing product, making sure it's dry, dabbed dry, and just protect the skin from urine and feces. We moisturising the skin, so if the skin's dry, moisturising it could increase its strength, less likely to get pressure sores developing. We want to avoid wet skin, so if you wash them, ensure that you dab dry them, ensure they're dry. Be careful with talcum powder, we'll talk about that in a separate presentation. Barrier products could be of some use, and that can be applied to moist skin areas to protect them. We need to prevent friction, so we should use slide sheets. Always the heel should be protected with either on a slide sheet, or you're going to cup them with your hands, which we'd go over in moving and positioning training. Always dab dry someone, don't rub the towel on their skin. Prevent shearing, so we want to have the headrest below 30 degrees, because above 30 degrees is when we get that shearing force starting. Nutrition is very important. If you got good nutrition, then you're going to have healthy skin. And the pressure sore prevention care plan will probably refer onto the nutrition care plan to address that. Skin assessment should occur daily, so when you're doing the daily wash, you're not just providing personal hygiene, you're assessing the resident, you're providing social contact, you're assessing their skin for bruising, for any rashes that have developed, anything that's you just don't recognize, but also the development of let's say category 0 pressure sores, especially on the pressure areas which I mentioned before, anywhere that is naturally more bony, like the hips, the heels, knees, etc. But that should happen every day. So if we catch a category 0, we can quite easily heal it, just turning them off that area, putting some, let's say, some Sudocrem on the area, reporting it handover, and it should heal very quickly. And then we need to also do like the formal risk assessment, the Waterlow score. There is also other ones such as the Braden, but we like to use the Waterlow score. We need to ensure it's done on admission within 2 hours, monthly after that, and when there's a change in their conditions, like after a hospital admission, etc. So that's, and there's other things we could put in that pressure prevention care plan. It could be less than this, but it's just some of the things that may be in the care plan, because it should be person centered. Okay, so if we can do all these things, then hopefully we can prevent the development of pressure sores.